hello, and welcome everyone to today's webinar, Hip and Joint Replacement. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Amanda Barnett, and I will be the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay along with a link to a short survey. Please take a moment to All right, we're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cindy Bourbeau. Cindy Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, case manager, nurse, life care planner, and legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads Medical and Life Care Consulting Services, a practice for professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services. Cindy founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the CNLCP Certification Board. She is also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. At this time, I'll pass it to Cindy Bourbeau.
Thanks, Amanda. First, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and injury stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So as always, get your questions ready. So for this year's second Injury Insight, Hip and Joint Replacement, we're pleased to have Dr. Jacob Drew. Today, Dr. Drew will guide us through an overview of both non-surgical and surgical treatments for joint pain, focusing on anterior hip replacement, a minimally invasive approach that significantly reduces recovery time. This session will also address revision arthroplasty, offering patients and failed joint replacements a pathway to regain mobility. Today's discussion will emphasize patient-centered care, guiding you all through the collaborative process of selecting the most suitable approach for each unique case. Dr. Jacob Drew is a board-certified orthopedic surgeon with fellowship training in hip and knee replacement. He completed his residency at the University of Massachusetts Medical School and an adult reconstruction fellowship at Ortho Carolina Hip and Knee Center. Dr. Drew has held roles such as Director of Arthroplasty Research at the Medical University of South Carolina and Chief of the Division of Arthroplasty at Beth Israel Deaconess Medical Center, where he taught within the Harvard Combined Orthopedic Residency Program. Dr. Drew treats a range of hip and knee conditions, offering both non-operative options like injections and physical therapy, as well as surgical solutions, including minimally invasive joint replacement. He is also skilled in revision arthroplasty for patients with complex joint replacement needs and performs surgery in various settings to best accommodate patient preferences. He is a member of the American Association of Hip and Knee Surgeons, the American Academy of Orthopedic Surgeons, and a fellow of the American Board of Orthopedic Surgeons. Before I turn this over to Dr. Drew, I just want to say a special thank you to him taking time out of his crazy busy day to participate in this program, and we really appreciate it. So with that, Dr. Drew, it's all yours. Go ahead and begin.
Thanks so much, Cindy. I'm just going to share my screen with you all here. All right. Thank you guys for being here, and thank you, Amanda and Cindy, for the intro. Um, I do mostly hip and knee replacement surgeries. That's the focus of my practice. And so I just wanted to talk today, not necessarily entirely about the surgical options, but also work through the non-surgical options, which is where we'll typically begin when we first meet a patient in the office. There are certainly a lot of patients out there with joint pain. This is a very common problem, I'm sure within the workman's comp world, but just with patients in general. So 1 out of 3 adults in the United States suffer from joint pain at some point at any given point in time. Over 100 million Americans have chronic pain, and over 50 million Americans have arthritis. The most common type of arthritis and what most people are referring to when we colloquially bring up arthritis in casual conversation is wear and tear arthritis. And so about 1 out of 4 adults suffer from wear and tear arthritis. There are many, many different causes for pain that exists within or about a joint. And there are many different anatomic structures that either make up the joint itself or are located immediately next to the joint. And, it's not always clear to patients which of these structures are problematic. It's not always clear to the doctors either. And so that's typically where we'll need to begin, is try to figure out exactly what the problem is. Now, many of the pathologies that we encounter sort of have a common pathway in terms of the treatments that we'll get into. But it is important to have an understanding for exactly what's going wrong in order to provide a patient with a realistic prognosis, expectations, and a treatment plan to hopefully get them feeling better. It's pretty rare that there's not some viable solution or pathway towards improvement with respect to joint pain. Almost always we can make this better. If not completely better forever, then certainly mostly better, at least temporarily. And so when we're talking about wear and tear arthritis, that is generally a disease of the articular cartilage. That's the cartilage cushion that exists at the ends of the bones at a joint. It's a smooth, shiny surface that, when it's in good condition, allows that joint to move freely and without pain. If that articular cartilage is injured or damaged or wears out, the tissues that surround the joint can become inflamed and irritated as well, and that can manifest as pain. And so some of those tissues might include the joint capsule, the ligaments, the tendons, the labrum for the hip or the shoulder, the meniscus in the knee. And of course, we have muscles and nerves that traverse the joint and allow it to function the way that we need it to. And so any and all of these structures can be involved in joint pain. And so the first thing we try to do is figure out exactly what's going on. Now, many times there's been an injury for the patients that we are dealing with respect to workman's compensation. And sometimes injuries are simply overuse. That might lead to a situation such as a tendonitis, where one of the soft tissues next to the knee joint, it just gets worked too hard for too long and it becomes irritated and inflamed. Other times there's a more dramatic injury. And so what we see depicted here, that brownish area where the articular cartilage is otherwise that white, shiny, smooth material, that represents an osteochondral defect. Sometimes that can occur. It's almost as though there's a divot on the golf course, right? And so that piece of cartilage with its underlying bone can be knocked free with the impact of an injury, and it leaves essentially a pothole in the joint. And that can contribute to further wear and tear and arthritis and pain. There can be fractures associated with injuries that can extend within the joint itself. That would be an intra-articular fracture. Generally speaking, those are going to be more problematic and severe than the extra-articular fractures, or those fractures that occur outside of a joint. Because you can imagine that surface of the joint needs to be smooth and in continuity in order to function properly. And so if there's a fracture that alters that normal smooth contour, even by just a few millimeters, that step off can lead to a situation where down the road, wear and tear arthritis develops when it may not have otherwise developed without that inciting precipitating event of the fracture. And so sometimes these injuries, such as this, can present with pain that can be dealt with and attended to in the short term. The patient feels better, but there may also be some long-term consequences, because once an injury involving the surface of the joint has occurred, that joint then is more susceptible to long-term issues such as osteoarthritis, wear and tear arthritis. It's not just the bone and the cartilage, what we think of as the solid structures in the knee that can be injured. We can also have injury to the soft tissues in the knee. And so if it's an isolated injury in the knee, such as a meniscus tear, the equivalent in the hip would be the labrum. These are fibrocartilaginous soft structures. They're almost a rubber-like consistency that extend around the periphery of the joint and add some stability. When these structures are injured in isolation, the rest of the joint is okay, they can be addressed. And so the picture on the left here depicts what often happens for a meniscus injury, which is a partial meniscectomy. That can be performed through tiny incisions and arthroscopic surgery with a camera and an instrument that's applied into the joint itself. And if it's a free edge of the meniscus like that, that can flip into the joint itself and cause problems. And so sometimes if that's the issue, we just need to trim it up and make it a nice smooth surface again. And so that material is removed. Now remember, wear and tear arthritis, the problem is that there's not enough material in the knee. That refers to the white cartilage that lines the joint. If we remove a large part of the meniscus, we're removing material, and now that articular cartilage basically has a more difficult job to do. Over the course of years after a meniscus tear, that articular cartilage that's working harder in the absence of the normal meniscus tissue may be more prone to wearing out. And that's, again, wear and tear arthritis. And again, here it's incited by an injury, not necessarily an injury to the cartilage itself, but an injury to an adjacent structure that makes that cartilage more susceptible to wear and tear down the line. And so if possible, if the meniscus tear, for example, follows a certain pattern where it's more adjacent to the periphery, we wouldn't want to remove such a large segment of that meniscus, because that's going to lead to arthritis quicker than we'd like. And so in some cases, the meniscus can be repaired. It's a slightly more complicated procedure. It's slightly less predictable than the meniscectomy that we talked about earlier, where you just trim the free edge. But the repair, if successful, could minimize that risk of wear and tear arthritis development down the road. And so if possible, particularly in a younger patient, if the injury lends itself to repair, that's a great option. I mentioned that the equivalent to the meniscus in the hip is the labrum. The hip and to a lesser extent the shoulder are ball and socket joints. And in each case, the socket is lined at the peripheral rim by a labrum. And so similar to the meniscus that we just looked at in the knee, the labrum is a rubbery consistency, soft tissue structure that adds some additional stability to the joint. And so if one suffers a labral tear, such as we see here, sometimes that can be repaired, sometimes it cannot be repaired. In instances where the labrum is torn and can't be repaired, now that hip joint doesn't function quite the way that it would. It's not quite as stable. And as a result, the articular cartilage at the surface of the joint right next to that labrum, again, is more susceptible to wear and tear down the road. So this is another instance where an initial injury sometimes is appropriate to be repaired. If it cannot be repaired, might lead to wear and tear arthritis down the road, post-traumatic arthritis. So that can happen in essentially any joint. We've talked about the knee, the hip, can also happen in the shoulder or other joints. And so ultimately, the end result of some of these injuries ends up being wear and tear arthritis. And so we see the normal picture on the left here. This is a knee with normal, shiny, smooth articular cartilage. It's a nice slippery surface for that joint to move freely. The meniscus are intact. They're providing some additional stability to the joint, versus the picture on the right where we see that there's been some wear and tear. That cartilage is no longer shiny, smooth, and slippery. Now it's pitted with defects, and that roughened surface creates a situation where all of the structures that surround the knee become irritated and inflamed, and it's painful. The joint might be swollen. It might be warm to the touch. Typically, with arthritis, one of the body's responses is to grow these bone spurs that are depicted here. And so if we were living in the dark ages and we didn't have access to surgical treatments, and arthritis was allowed to run its course with no medical intervention, ultimately what eventually happens is those bone spurs grow all the way across the joint, and the joint becomes fused. It doesn't move anymore. If you're a caveman living out in the wild, if your joint becomes fused, it might not work quite as well as it once did, but it's not painful anymore. So there's some theory that there's some survival benefit, and the body has sort of developed this natural history of unattended arthritis is going to lead ultimately to a fused joint, which won't hurt, won't work quite as well as it did, but the caveman survived. So isn't that great? Fortunately, we're not living in the dark ages, and we have access to medical treatments. And so ultimately, long before it gets to this point, we could perform a surgery. But really what we want to do is not ever get to that point to begin with. And so injury prevention, there are some strategies that can be effective. And so, if we want to prevent fractures, we want to make sure our bones are as strong as they can be. Calcium, vitamin D, dairy products, milk, eggs, and cheese, it's good to do that. This time of year, it's great to get out in the sunlight. Right. So you can consume all the vitamin D that you want. Vitamin D requires sunlight to be activated in order to actually lead to increased bone density. So drink your glass of milk in the morning and then get out during the daytime when it's 100 degrees outside, get some sunlight, activate that vitamin D and start building your bones. Weight-bearing exercise is going to help build bone density and preserve bone strength. Unfortunately for all of us, after we hit our mid-20s, it's a steady decline in terms of our bone health and our bone density. It doesn't matter if you're active, male, female. Once you hit those late 20s, the worst is behind you in terms of your bone density. And so we want to do what we can to slow that decline, right? And proper diet, calcium, vitamin D, weight-bearing exercise. And you don't want to hit the ground running literally. If you're not somebody who's exercised, if you go out and try to run a 10K tomorrow, you're probably going to get hurt one way or the other. And so the important things to warm up, to stretch, and to gradually increase your activity over the course of weeks or even months. Work up to it. Don't just do too much right away. You'll end up setting yourself back. So wear and tear prevention, if we're going to do weight-bearing exercise to build bone density, the gentlest exercise on your joints are those exercises that are low impact, and ideally exercise that takes gravity completely out of the equation is ideal. So swimming is great. That's a good one. For example, elliptical would be better than running on pavement, right? Running on pavement, you're pounding your joints. Elliptical is a nice, smooth, low impact exercise. And so those are the ways to stay out of trouble. But once an injury or a tendonitis, overuse, wear and tear arthritis, once those things come about, what can we do to treat that and make patients feel better? I have many patients coming into my office who have heard about or done some self-guided internet research on these things. So biologic therapies, platelet-rich plasma stem cells being the popular ones. Lately, there are some proprietary private clinics that offer various other forms of biologic therapies. They're very popular as radio ads in the Boston area. I hear them all the time, and patients are always asking me about them. So what is platelet-rich plasma, for example? Platelet-rich plasma is, the way we get it is we take a sample of a patient's blood, small sample, a test tube full. When you spin that test that promote healing, if we can just and then put them where we need them, meaning into a joint, next to a tendon, etc., then all those platelet superpowers in a high concentration are going to facilitate healing of whatever injury we might have. And so it sounds great in theory. There are definitely patients who have this done who feel better. Whether the natural history of whatever problem they had was actually altered by the platelets or whether it was just going to get better anyways is debatable. Insurance companies generally don't cover platelet-rich plasma treatment because it's not yet scientifically proven that it works any better than some of the other treatments we have. And so patients generally have to pay out of pocket for this. There's probably no harm to it, but again, it's sort of debatable whether it works. Stem cells are something similar but related. So stem cells are present within our bodies. They're a sort of infant cells, if you will, that can potentially go down one path or another and form tissues, right? So stem cells have the potential to form, theoretically, heart cells. They have the potential to form brain cells. They have the potential to form cartilage. Potential, right? So it's really hard to steer the stem cells down a certain path. And so the thought is if you put stem cells in an area of injury, the body will guide those stem cells to form the tissue that's going to heal said injury. Again, little evidence that that actually works or happens. Maybe it does. Seems like something we're eventually going to be able to figure out, but the science right now doesn't suggest that we've figured that out yet. And so you're seeing a common theme for some of these newer emerging biologic therapies. There's promise. Theoretically, they make sense, but I'm not sure that they're quite ready for prime time yet. All right, so patients will ask about this. I generally don't dissuade them from it other than to say, hey, look, it might work, it might not, and it's going to cost you some money generally. The more well-proven treatments are the tried and true, the old-fashioned. So anti-inflammatory medications, over-the-counter, Motrin, Aleve, ibuprofen. There's some prescription strength versions that are a little bit easier to take that might last a little bit longer. For almost every joint problem, this is our first strategy, right? And so, when I have people coming up at my kids' baseball game, say, hey, I heard you're a doctor. What do I do for my knee pain, my shoulder pain, etc.? This is almost always what I tell them to do first. Same thing with patients in the office of arthritis or tendonitis. Anything with an itis at the end of it is inflammation. The treatment for any sort of inflammation is going to be an anti-inflammatory medication. And these are good options. Now, they're good options for most patients. There's a lot of patients who have other medical conditions that make these medications a little bit dangerous. So they can be hard on the lining of the stomach. Patients who had ulcers can't take these. Patients who have kidney disease, these medications can make that worse. Sometimes patients who have cardiovascular disease or are on blood thinners, these are not great options. All right. So sort of our second choice for over-the-counter medications, pills that can help with a lot of this joint pain is Tylenol. Tylenol is a lot of people's first choice because it's handy, it's popular, it's a common medication. Most people have it in their medicine cabinet at home. The problem is Tylenol doesn't work great against inflammation. So all of these arthritis, bursitis, tendonitis, Tylenol might help a little bit, but generally not as well as the anti-inflammatories. And so this picture here, Tylenol arthritis, that's a great marketing strategy to try to get patients to buy Tylenol for arthritis. The only difference between Tylenol arthritis and regular Tylenol is that this one lasts maybe 2 hours longer. It's not an anti-inflammatory. It's not any more effective against arthritis or any of the other itises. Again, the anti-inflammatories are the far more effective class of medicine. There are a lot of not medicines, but natural herbal supplements that are available at places like GNC. Similar to what we talked about with the PRP and stem cells. These might work. They probably don't cause any harm. They're going to cost the patient some money because they're generally not covered by insurance. And they might work. I have some patients who take this regularly and have done so for years, and they swear by it. They swear that they take these supplements, which are thought to be the building blocks of cartilage. Do they actually make it through your digestive tract, your stomach, and somehow end up in your knee joint building cartilage? Probably not. But theoretically, maybe they do. So again, I don't dissuade patients from trying these, but the reality is they probably don't work for the vast majority of patients. And so there are all sorts of other gadgets, potions, and spells, right? So kinesio taping, copper bracelets, all these different bands and braces. If you have instability, a brace can help provide mechanical stability to your knee. For most of the other problems that we're talking about, it's probably not going to help a whole lot. But again, patients try this. They believe in the gadget, potion, or spell, and there's some benefit to that. All of the above, none of these things are generally going to cause harm. And so if a patient wants to try these, great. And if they feel like it helps, even better. I'm all for it. These are, again, some of the natural herbal supplements that patients can have access to without a prescription at nutrition centers, et cetera. These ones that are listed on the top absolutely have anti-inflammatory properties. That's why they work. Turmeric is a great one, ginger, fish oil. These have natural occurring anti-inflammatory properties. And so for the same reason that anti-inflammatory Aleve helps with your joint pain, so does some turmeric sprinkled on your oatmeal in the morning. I'm not sure if that would taste good, but just an example. So these all have demonstrated efficacy in clinical trials. They're not quite as efficacious as the medications are. Some of these may interact with medication. And so I always advise patients to just check with their pharmacists who tend to know more about those things. And maybe some of these have side effects that we don't really understand when they're all mixed together. And so there's some element of caution with these natural herbal supplements that should be followed. But for the most part, these are safe and relatively inexpensive ways to get some anti-inflammatory benefit to most of the causes of joint pain. So what happens if all of this stuff, all of these other stuff fail? And I should add that other treatments that are generally helpful would include corticosteroid injections, gel injections. Those can occur both in the hip and the knee and the shoulder, any joint. Steroids are a medicine. They're a powerful anti-inflammatory. That's how they work when we inject them. The gel is basically just a lubricant. It's an oil change for your knee joint. Both of those can work. They're generally temporary. They won't work forever. And over an extended period of time, they'll become less and less effective as the arthritis or whatever other problem becomes a little bit worse. And so in order to become a surgical candidate, patients will have needed to try at least some of those options. They don't necessarily need to exhaust the entire list, but you need to try some of those non-operative treatments first. And so if anti-inflammatory medications, modifying your activity, maybe using a cane or a crutch or a brace, physical therapy, injections, if those aren't working, joint replacement becomes the final common pathway. And so for hip replacement, what we're doing, this is a ball and a socket joint. We need to give that joint a new surface. So remember that picture we showed earlier of the wear and tear arthritis. The smooth, shiny, slippery cartilage is now pitted and worn out, and it doesn't work right anymore. There's bone spurs. The joint's not moving as it should. We need to give that joint a new surface. And essentially, that's what joint replacement is, giving that worn out surface a fresh start, usually with metal and plastic. And so before the surgery, we do what's called templating. We sort of measure twice and hopefully cut once. We try to determine the size of the parts, the position of the parts that are going to go in, and then we perform the surgery. And so there are a few different ways to do hip replacement. Patients will, again, maybe have done some internet research and they didn't know about the anterior approach or the lateral approach or these various different options. At the end of the day, the hip replacement itself is exactly the same, no matter which approach you use. It's just the approach determines how you get to the joint. Once you're at the joint, all the steps are the same, no matter how we got there. My preference is an anterior approach that parts the muscles. So we just open the curtains. Because of that, the recovery tends to be a little bit quicker. We also have the advantage with an anterior approach, the patient is lying on their back. And it's very easy to use an X-ray machine to make sure that our parts end up exactly where we've decided they ought to be with our templating. Other hip replacement options, posterior approach, lateral approach, they're perfectly fine. They just go through a different pathway on the way into the hip. And those different pathways involve either cutting or splitting muscles rather than parting the curtains. And so for myself, the anterior approach is, a more gentle way, does less damage. And science has shown that there's probably some early advantage in a quicker recovery. I would say that early advantage is modest. And no matter which approach a surgeon chooses, as long as they do a good job of handling the muscles and the soft tissues, as long as they do a good job of having an appropriate plan and carrying out that plan, the patient should do really well. And so once we get into the hip joint, we need to get rid of that ball. That ball is no good anymore. The surface of it is worn out. And furthermore, it's in the way of us doing what we need to do to prepare the bones for the hip replacement. And so you can see this metal guide here tells us where we're going to cut that bone, and everything above that metal is going to go away. And so that allows us a clear view. Now that that ball is out of the way, we can access the socket, which is called the acetabulum. We talked about that labrum earlier. Remember, sometimes patients have labral tears, and that's what leads to their hip replacement. They always want to know, what are you going to do with the labrum? We get rid of the labrum in every hip replacement. When we do a knee replacement, we get rid of the meniscus in every knee replacement. So patients don't have to worry about those structures causing problems anymore, because after the joint replacement surgery, those structures are gone. And the way we prepare the socket itself is we use something called a reamer. In real life, this looks a lot like a cheese grater, and we hook it up to a power. It looks just like a drill. And we start with a small size, which is depicted in part A here. And then we gradually get bigger and bigger and bigger until we get up to the appropriate size of the socket. And I generally don't know exactly which size a patient's going to need until we get into the operation. I tell patients that, joint replacement is like going to the shoe store. We have sizes and half sizes on the shelf ready to go. We just have to figure out which size fits that particular patient. And the way we do this is by preparing that socket with these reamers or cheese graters, if you will. When we get to the right size, we pick that size off the shelf and we impact it so that it's a nice, tight, solid fit. We do the same thing on the other side of the joint, the femur. So you can see here we've cut that bone. The ball is no longer there, and that gives us access to the hollow femur bone. And so we can prepare it with these structures. They're called broaches, and they get larger and larger until we get to the size that fits. And once we get to the size that fits, we take the final implant, which is the same shape as this brooch, and impact it until it's a very tight fit. And so those parts are tightly impacted into the bone. The surface of those metal parts is such that the bone will actually grow into the surface of the metal. The surface of the metal almost looks like a very fine sponge, which the bone grows into. And so essentially within 6 to 8 weeks after the surgery, those metal parts are one with the patient, as long as everything goes well. We have the ability to put different lengths and sizes. And so we can make sure that we reproduce the hip joint exactly where it needs to be so that the muscles that are at the appropriate tension. Patient will have appropriate muscle strength, walk without a limp, and the hip won't pop out or dislocate. And so we have various ways to do that. You can see here, if I wanted to, I could make just about every hip replacement patient an inch taller if I did both hips. Usually we're just doing one hip, and the patients don't want one leg an inch taller than the other one. So we have to be very careful and attentive to make sure that we insert the metal pieces to the appropriate spot. That's why that templating and planning is important. And if we put it in the right spot, we should put their leg length exactly back where it ought to be. We have to test the stability of the hip joint. If we don't reproduce the leg length and the muscle tension, then that hip is going to be a little bit floppy. If it's floppy, it can pop out of the socket and dislocate. That lands the patient back in the emergency room. And so before we put the final parts in, we take it through a range of motion and make sure that the stability of that hip joint is going to be appropriate. We expect the hip replacement to last a patient 25 years. If we do a good job, no matter which approach we took to get into the joint, 25 years is the expectation. Now, knee replacement, it's sort of a similar story. When do you get a knee replacement? Who gets a knee replacement? You've tried all that stuff, that other stuff, the medications, the braces, the injections, and that other stuff is not working well enough. And so when patients come back to the office and we're trying to make that decision, I ask them a very simple question. Did the injection, did the medicine, did all this other stuff work well enough, or do we need to do better? And if we need to do better and we've tried everything else, knee replacement is it. And so the concept and the principle is very similar to a hip replacement. Generally speaking, there's only one way in and out of the knee. It's not these various anterior, posterior, lateral options like there is in the hip. Everybody comes at the knee from the front because all the dangerous structures live in the back. And so once we get in there, we get the kneecap out of the way, and we need to just take out or remove the damaged surface of the joint. And so that's what's depicted here in these images up top. We make these cuts, 5 on the femur, 1 on the patella, and 1 on the tibia. And once we have those surfaces cut, now we can put the new implants in. So you can see here in the picture, part A, that bone has been prepared. We've made our precise cuts to accommodate the metal femur that's depicted in B. What we see here is the patella. We've cut that flat, and the new plastic button is going to fit right under surface of that kneecap. Down here in E, we've cut the tibia flat, which will accept a metal component. And then we have this plastic insert that goes between the 2 metal pieces. So is to put those metal parts in nice and tight with a metal surface coating that allows the bone to grow into the metal. That is now an option with knee replacement, but that's really only been a widespread option for the last 5 to 10 years. Historically, we've always put a layer of bone cement between the metal and the bone that acts as a grout, but it bonds the metal to the bone. It's been a little bit trickier to figure out the technical needs of a knee replacement where the bone grows directly into the metal, but we seem to have figured that out over the past 5 to 10 years. And so now, as long as those cuts are perfect, the metal pieces fit on there perfectly, it's nice and stable, and the bone should grow into the metal. And so we have that option, which is a great option, particularly for our younger patients. It's probably going to extend the lifespan of knee replacements. Cemented knee replacements, that cement bond can be a weak link that tends to fail around 20 years or so. So without having to rely on that cement, theoretically at least, perhaps we can get total knee replacements to last as long as we see total hip replacements last, somewhere around 25 years or perhaps even more. There is another option in the knee that is less relevant to the hip, but in the knee, if you only have arthritis in one part of the joint, we can do a partial knee replacement. So we don't need to address the other part of the joint if all those structures, the cartilage, the meniscus, etc., remain intact. If it's only this one part that's damaged, we only have to give that one part of the joint a new surface. And again, this is metal and plastic. It's the same principles, making perfect cuts, bonding those implants to the bone with either cement or perfect cuts. The only difference here is that these partial joint replacements tend to be a much easier recovery, and they tend to function more like a normal knee compared to the total knee replacement. Now, when a patient is going to get a total knee replacement from me, I always warn them that it's not going to be perfect in the end. The ways that a total knee replacement falls short of perfect, kneeling will always be uncomfortable. The knee will feel like a mechanical knee. If they're sitting down and their foot's free and they just sort of shake their leg side to side, a knee replacement will go tap, tap, click, click. And that's normal. That's okay. It's not a problem. It just can be a little bit off-putting to some patients when they first experience that. Total knee replacements will always have some limitation as well. So I allow patients to walk, hike, bike, swim. They can run and jump if they want to run and jump. But the more you do, the more higher level activity that you do, eventually you reach a point where the knee replacement is just not going to live up to those demands. And it might be achy and swollen and painful for a couple of days until it settles down. Those limitations are all less with a partial knee replacement. And so if the patient is an appropriate candidate, meaning the arthritis is only on that one part of the knee, this is a really nice option to achieve a higher performance knee with a little bit easier recovery. Sometimes knee replacements go bad. Sometimes hip replacements go bad. So what could go wrong? So just to give you a couple of examples of how these go bad. Number one, they can come loose from the bone. If that's the case, we have to go back in, pull all those parts out and make sure they fix again, sometimes with some additional metal or plastic. Instability is a common one. So you can imagine if we put in the knee joint where it's floppy, those ligaments are not stretched tight, it's unstable. How do we fix that? Well, sometimes it's as simple as going back in and putting a thicker piece of plastic that pulls those ligaments apart, pulls them taut so there's no slack, and that can provide some stability in a joint where that previously had been a problem. Sometimes we need to do more than just thicker plastic. Sometimes we need to pull all of the metal parts out. When we do that and we put new metal parts back in, oftentimes we'll add what's called a stem. That's this piece that, again, goes into the hollow bone and provides some additional stability that can be necessary if we have to go back in and fix something that went wrong, because inevitably, once we do that, there's been some bone loss. And those cuts that we needed to be perfect, we can't make them perfect. So if the cuts can't be perfect, we need to gain some stability some other way. And oftentimes that's when with some additional metal in the stems that are depicted here. So on the left here, this is an example of a normal first time around knee replacement. On the right, this would be an example of a typical revision knee replacement where we add this extra metal for stability. Sometimes we have to add metal for stability across the joint itself. We can go all the way up to a hinge where this knee becomes essentially like the hinge on your front door at home. We try not to do that. There are some downsides to that. They tend not to last as long as the normal knee replacement that relies on ligaments and tendons. But sometimes if the patient's ligaments and tendons are no longer suitable to provide stability on their own, we need to get stability through more metal and more plastic. The vast majority of time, knee replacements and hip replacements are going to work great and they're going to last a long period of time. We do rely often on the patient's own anatomy, the ligaments, the tendons, the shape of the bones to provide stability. Sometimes we have to rely on the implants to add more stability. The more we rely on the implants, the greater likelihood that they're going to wear out sooner than we would want them to. And so the trick is to balance what the patient is providing with hopefully normal intact anatomy other than the surface of the joint. But if we run into problems where those anatomical structures just aren't good enough to give a solid joint replacement, sometimes we have to increase the amount of metal that we put in there. And so that's basically the overview that I was hoping to talk with you folks about today. And so, we'll hopefully have a few minutes for questions if anything comes to mind for you guys. But thank you very much for your attention. I'm happy to answer any questions that you might have.
Fantastic. Thank you so much, Dr. Drew, for sharing so much information and insight about hip and joint replacement. I will just share on my side. Okay, fantastic. So at this time, we'll shift into our question and answer session. Please be sure to submit your questions using the Q&A feature within the Zoom dashboard. And we would really appreciate if you could scan the QR code you see on the screen and complete this session survey. You'll want to select the hip and joint replacement webinar in the dropdown, and it will take about 2 minutes to complete our survey. In the meantime, let's take a look at some of the questions submitted to Dr. Drew. So I know that we have one question here. Let's see. Can you speak to preoperative nicotine and A1C testing in consideration of hip surgeries? Do you obtain either of those, especially in patients known to be a tobacco user or diabetic? And if so, how do those results influence surgical recommendations?
That's a great question. So I'll speak to those separately because they're handled a little bit differently for, mainly logistical reasons. So hemoglobin A1C testing, that's basically a long-term measure of blood sugar control. And so that's relevant in patients who are diabetics. Diabetics have a greater likelihood of infection, particularly if their blood sugar is poorly controlled immediately after surgery. And so we use hemoglobin A1C as a predictor of how well a diabetic's blood sugar is likely to be controlled in the days and weeks immediately following surgery. If a hemoglobin A1C is very high, that tells us that that particular patient, their diabetes is not controlled well enough to present with the lowest possible likelihood of infection. And so I think the vast majority of joint replacement surgeons will have a cutoff for hemoglobin A1C. And so above a certain number, basically we say, hey, look, your risk for infection is too high because this number tells us that your diabetes is not well enough controlled right now. And so in the spirit of optimizing that patient, putting them in the best possible situation to have an excellent outcome from surgery, we can do better, right? We can intervene, or more specifically, their primary care doctor can intervene and potentially change diabetic medications, change diet, do something that achieves better diabetes control leading up to surgery, which predicts that that patient will have better diabetes control in the days and weeks after surgery, when it's really important to help us avoid infection. And so if A1C testing yields a number that's above our cutoff, we will typically postpone surgery until that number falls within range. It's a similar principle for patients who are smokers using nicotine. And so it's not just smoking. Some patients use chewing tobacco, some patients use nicotine patches or any other way of getting nicotine. Nicotine is the problem. So nicotine constricts blood vessels, makes wound healing less predictable, and again, increases the risk of infection. So ideally, we want all of our patients to be nicotine-free leading up to surgery. And so patients who are smokers or tobacco users of some sort will generally advise they need to quit whatever nicotine product they're using 4 to 6 weeks in advance of surgery, stay quit for 4 to 6 weeks after in order to facilitate wound healing, et cetera. The problem is that's difficult to determine and enforce, right? And so we can test for nicotine in the urine, but it's not a perfect test. If there's somebody else in the home smoking, secondhand smoke can lead to an increased value. The nicotine levels can remain elevated for a period of time. If the patient quits smoking, but they're weaning off with either nicotine gum or a nicotine patch, again, that's going to stay in the system. And so what I will do is explain to the patient why nicotine is problematic, explain to the patient that we'd like them to quit, and then use that testing sort of as an honor system. And if the patient says they can't quit, I'll delay their surgery until they will. I won't do a surgery if a patient admits to actively smoking cigarettes. Now, I am not completely naive to the fact that plenty of patients probably, work around this. And that's a problem that we can't solve with 100% certainty, right? The patient gets a test a couple of weeks before surgery, the nicotine's low enough, all right, we're a go, and they go back to smoking. I'm sure that happens. I think simply educating the patient, allowing them to be an active participant in their health, having them understand, and to the best we can, documenting what's going on. So with nicotine, it's a little bit less cut and dry than it is with the diabetes, but we do try to do the best we can to give these patients the best chance of a successful outcome.
Fantastic. Next question. How do you know the need for replacement is due to strain, sprain, or work injury?
So sprain or strain itself would not be likely at all to lead to a replacement down the road. So a sprain or a strain, that generally is a self-limiting temporary injury to a ligament or a tendon. Unless that ligament or tendon is completely rendered useless, which would be a tear, sort of the next level up from a sprain or a strain. Unless it reaches that level, it's unlikely to be a significant enough problem that's going to lead to the joint wearing out, right? So the joint wearing out is what ultimately necessitates a joint replacement. So I would expect most sprains and strains to heal themselves with supportive treatment, maybe a period of immobilization, maybe a period of bracing, anti-inflammatory medications. If it rises to the next level and that sprain or strain becomes a tear, that might require some surgery to fix. But it wouldn't necessarily require a replacement unless or until the entire joint wore out as a result of that, which is a pretty unlikely scenario.
Great. And next, do partial knees fail sooner than total knees?
They do. So total knee replacement, I usually tell a patient I expect it to last 20 years or more. For a partial knee replacement, I tell a patient that it's probably going to last somewhere around 15 to 18 years. So partial knees do fail sooner than total knees, not by a lot. It's not like a partial knee lasts 3 years and a total knee lasts 20. It's in the ballpark, 15, 16 years versus maybe 19 or 20. That said, partial knees during those 15 to 18 years are going to perform at a higher level than a total knee. And so I do believe there's value in partial knees, even if they don't last quite as long as the total knee would have. Whatever amount of time, 15 to 18 years that you have with your partial knee, it's probably going to be a better 15 or 18 years than it would be if you had had a total knee to begin with. When the partial knee fails, we generally turn that into a total knee replacement. And at that point, I would expect that total knee replacement to last 20 years beyond.
Fantastic. And then one more question. What time are patients out of work, and at what point are they full functioning?
So there's a lot of variables with that. And so I'll try to speak in generalities with some specifics. Hip replacement is overall an easier recovery than knee replacement. And so I'll tell patients who are getting a hip replacement, expect to be on crutches for a couple of weeks. Within a month, you're feeling better than you feel before the surgery. Knee replacement, I'd expect to be on crutches or a walker for maybe 3 or 4 weeks. The first month is miserable. Somewhere around 4 to 6 weeks, you turn the corner and start feeling better. And so there's a difference between hip and knee when you can get back to work. There's also a lot of variability in the nature of a patient's job. Somebody whose job is sitting at a computer and answering phones, if they want to check their email and supervise their employees from afar, they can probably get back to doing that within a couple of weeks once they're off of the pain medications. A heavy laborer, it's probably going to be closer to 3 months, regardless of which operation they had, before they're ready to get back and perform the full duties of that job. I would say pretty rarely it's longer than 3 months. After about 3 months, people are generally back to doing everything they want to do. And I tell patients to expect to get back to that state of doing everything you want to do sometime between 1 and 3 months. And so for a patient who's fit, healthy, active, motivated, at a month after a hip replacement, they're almost back to normal. For a patient who's inactive, not fit, not motivated, after a knee replacement, they're probably going to take the full 3 months to get back, and maybe even a little bit longer.
Okay, great. I think that concludes our question and answer, and we're just about at the hour. So we want to thank you all for joining MLCC's second Injury Insight webinar of 2025. Playback of this webinar will be available within 48 to 72 hours. Additionally, we ask that you take the time to complete the webinar survey if you haven't yet. And for those who attended live, please anticipate your certificates of completion within 48 to 72 hours as well. And thank you again to Dr. Drew. We know that our attendees really enjoy learning from specialists like yourself. And our last plug of the day is our next Injury Insight, which will be held on September 24th, TBI, Traumatic Brain Injury Diagnostics with Dr. West Center. If you haven't yet, visit our website, medicalandlifecare.com, head over to the webinar dropdown and register for our next session. With that, we will conclude today's webinar. Thank you again for watching. Our hosts, Dr. Drew and Cindy, and we look forward to the next session.
Thanks, everybody. Have a great day.
Thank you.